All right, let's jump right in. We're going to do a quick and dirty, super high-yield crash course on one of the most critical tools in the ICU, the arterial line.
So, picture this. You're in the ICU, your patient is crashing, their blood pressure is totally unstable. That cuff pressure? Yeah, you can't trust it. How do you really know what's going on, beat by beat?
Well, that's where the arterial line, or A-line, as we all call it, comes in. Think of it as a direct, unfiltered window into your patient's real-time hemodynamics. It gives you that beat-to-beat blood pressure and, bonus, super easy access for all those blood draws. Okay, so when do you actually need one? It really boils down to two main things. First, hemodynamic monitoring. If your patient's in shock or you're using powerful blood pressure drugs, you need that constant feedback. And second, frequent ABGs. If someone's on a ventilator, you're going to be drawing a lot of arterial blood gases. So just remember, pressure and gas. That's why you place an A-line.
And this right here, this is a huge ICU pearl. I mean, it's pretty much an unbreakable rule. If you are actively titrating vasoactive drugs, pressors, you need an arterial line. It's not a suggestion. It's absolutely non-negotiable for patient safety.
All right, so we've covered the why. Now let's get into the how. We're talking about placement, the different sites, and the technique.
When you're choosing a spot, it's usually a showdown between two main arteries. First up is the radial artery. It's our go-to, our first choice, mainly because it's safer, it's easy to get to, and it's got great collateral circulation. But in a code or a true crash and burn situation, the femoral artery is your friend. It's a bigger target, so it's faster, and you have a better shot at getting it. The bottom line is really simple. Radial is safer, femoral is faster.
And speaking of safety, let's stick with the radial artery for a second. This is absolutely crucial. Before you even think about sticking a needle in that radial artery, you have to confirm there's good collateral blood flow. You can do this with a classic modified Allen test, or even better, just use your ultrasound.
Which, brings us to the modern standard of care. Seriously, ultrasound-guided insertion is the way to go. This isn't just for fun. It means you're more likely to get the line on the first try, you'll have fewer complications, and honestly, it's pretty much essential if your patient's blood pressure is so low you can't even feel a pulse. Okay, but it's not all sunshine and roses. Like any invasive procedure, A-lines have risks. So let's talk about the big, scary complications you need to be watching for. This is super important stuff, not just for exams, but for your actual patients.
All right, what's the number one thing that keeps us up at night with A-lines? It's this: thrombosis leading to limb ischemia. Basically, a clot forms and cuts off blood supply to the hand or foot. This is a huge deal, a true limb-threatening emergency.
So how do you know it's happening? You've got to look for the telltale signs. The limb looks pale, it hurts, the pulses are weak or gone, and capillary refill takes forever. If you even suspect this is happening, what do? You don't wait. You pull that line out immediately.
Now, besides losing a limb, what else can go wrong? Well, you've got your usual suspects. Infection, which gets riskier the longer the line stays in, and of course you can get bleeding or a nasty hematoma at the insertion site.
So, after all that, what's the one thing you need to remember? It's simple, and trust me, it's an absolute exam favorite. If you have an unstable patient in the ICU, your brain should immediately be thinking, does this person need an A-line? Think early. It is a cornerstone of critical care.